Welcome, everyone, to the July 2021 edition of the Prehospital Care Research Forum Journal Club podcast. The Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. We believe it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. And here, with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and today I'm joined by Dave Page, Dr. Tony Fernandez, Dr. Bill Toon, and Jeff Rollman. The name of the article we'll be reviewing today is Routine Use of a Bougie Improves First Attempt Intubation Success in Out-of-Hospital Setting, and this was published earlier this year in Annals of Emergency Medicine. As always, our discussion is paired with an article written by our very own columnist, Dr. Tony Fernandez, called Journal Watch. And we encourage you all to check out the article. It'll be on emsworld.com under the category of education and training. I want to thank all of you for joining us from far and wide, some at early hours of the morning. And as we begin, I do want to remind listeners, you can all use your chat feature on the screen to type in questions and comments, and we will be bringing those into the conversation as we go. So go ahead and say a friendly hello in there. And without further ado, let's go ahead and just dive right in. So today's article is all about the airway, an important near and dear topic for a number of reasons. For the most part, in many EMS systems, airway procedures are one of those high-risk, low-frequency events. And we know that shorter airway attempt times are better for avoiding oxygen desaturation and a number of complications, and this is linked to better outcomes for our patients. So we also know that bougies are a device sometimes used by EMS clinicians. And I'm going to actually ask one of our panelists to help me out. And let's talk a little bit about, before we even dive into this, what is a bougie? So Dave.
Yeah, for those joining us that are not familiar with these devices, it's an endotracheal tube introducer. And the concept is that with a smaller, more rigid, longer, thinner device, you can possibly slide that in between the vocal cords when you're doing an endotracheal intubation a little bit easier. There are several versions made by different manufacturers of these devices. The original one was made by gum elastic, made of gum elastic bougie. I'll get this out, and it actually comes from the resin from a tree. There have since been, and it's expensive. In some cases, it can be about $70 per introducer. The other more common device that we see pre-hospitally is a blue plastic device. It's a little less rigid. So these are meant to bend a bit, but storage of these long devices has been an issue. And so that's kind of part of the equipment that most people who are intubating at this point do carry or should carry, I guess. And the blue one comes with, I guess I shouldn't really define it by color because it depends on which manufacturer, but it's a little bit more wangly, I guess, less rigid and made of plastic versus the gum elastic, which is the tree resin. So these are a couple of different options to assist the intubator to slide something in that's not as large as the endotracheal tube, and that then once in, you can feed the endotracheal tube over the top of it. It sort of acts as a guide. And the other nice little feature is that the end is like a hockey stick. It's got a little bend to it, so you've got a little more aiming ability to kind of come around a bend or a corner if you're looking down the gauntlet, so to speak. Hopefully that gets us centered as to what these devices are, and then I'll wait for the discussion to editorialize on my opinion of these devices. So stay tuned.
Oh, well, that was an excellent introduction. And I mean, bougie is just kind of a fun word to say, so I'm not gonna lie, that was part of what got my curiosity going when we were preparing for this podcast. This article got me thinking about where the word even came from. So curious, any of our panelists know the origins of the word bougie?
Well, in French, it's a candle, actually. So that's interesting as far as that's concerned. Maybe it has a different epistemological, is that the right word? I'm just butchering that, but
I'm one of those big E words, I don't know. But actually, yeah, it does. So it is the French word for a wax candle, and it's named after an Algerian town that made wax and exported candles. And as it would turn out, medical instruments used to be made out of linen covered with wax. And so that's where the word came from.
love it.
Okay, well, back on task. All right. We should talk probably about exactly what question this study was actually trying to answer. And so, like Dave kind of introduced here, the author said, we know that a bougie can help in a difficult situation, but if using it in hard times improves success, what would happen if we just used a bougie all the time? And so in this study, the authors examined the effect of a protocol change that included routine use of a bougie on all endotracheal intubations, and they looked at its effects on first pass success. And I'm going to turn it over to Dr. Fernandez just to tell us a little bit about what the investigators needed to go about answering this important research question. Dr. Fernandez, take us away.
Hello, and thanks everyone for joining us today. So this was a really fun study, and let's talk about how they did it and what they found. So this was a prospective observational intention to treat pre-post analysis after a policy change. Now, as you can see from my little flubbing the line there, that's a mouthful, but let's kind of unpack that a little bit. So what they did was they designed the study before they collected any data, and essentially what they did was they watched what happened after they implemented the intervention, which was use of the bougie. And the policy was that the bougie would be used on all intubations, regardless of the difficulty, after January 1, 2017. So intention to treat, we talk about this a lot in medical research. And what intention to treat is this is a way to compare based on what group you were supposed to be in, right? So in the pre part of this study, folks were not supposed to necessarily be using a bougie for all intubations, but they could have. In the post part, they were supposed to be using a bougie for every intubation attempt. That didn't always happen, as we'll see later. But the pre and post analysis were they were compared against each other as if 100% of folks used a bougie post and 0% used a bougie pre. So we'll get through that and see some of the implications of that analysis as we move forward. So the study, as we talked about, was done in Seattle Fire Department, and in Seattle, Seattle FD, they're the sole provider of EMS. All of the paramedics were said to be proficient in RSI using sedatives and neuromuscular blocking agents. So they performed intubation with direct laryngoscopy with Macintosh blades, and that'll be important also as we move forward. So keep an eye on that, as well as noting that they did not use video laryngoscopy in this system. So, and these paramedics are, to keep proficiency in their intubation skills, they were to perform at least 10 intubations annually. If they couldn't get those in the out-of-hospital setting, they did complete their 10 in hospital. So let's talk about who they studied. So this study took place from July 1st, 2015 to September 30th, 2018. They included all patients with attempts at airway management by paramedics in Seattle. So the study period included 18 months pre and 18 months post implementation of the Bougie protocol. Going forward, we'll call the pre period the control period, and the Bougie period will be our post period. And they had some important exclusion criteria. So kids younger or patients younger than 16 were excluded. Use of any supraglottic devices or crikes without laryngoscopy were also excluded. And any intubation attempts by paramedic students were also excluded. There were some issues with paramedic students kind of crossing between both of the study periods, and they thought that it was cleaner, I believe, to just exclude the paramedic students rather than have to adjust for their skill levels. They had audio recordings, and they also collected things like EKG strips, ETCO2, capnography, and pulse ox from the actual monitors. So they had a wealth of data to record as well. And the paramedics were, because they had audio recordings, paramedics in the system are trained to verbally identify treatments as they're being delivered. So if they're delivering drugs, if they're using any adjuncts, as they begin or end the intubation attempts, they verbalize that so it can be heard on the recordings. They're variable, so they adjusted for some things. They didn't just look at these success rates in isolation. So they ran some models and they adjusted for things that they can collect in their registry, which included the patient demographics, indications for the intubation. They had their airway grades, medications given, all the adjuncts used. And so all of this was taken into account when they were comparing their pre and post success rates. Their primary outcome was first attempt intubation success. So they defined this as successful placement of the endotracheal tube in the trachea on the first laryngoscopy attempt. A laryngoscopy attempt was defined as laryngoscope blade passing the teeth, regardless of whether they placed an endotracheal tube or a bougie. They looked at some secondary outcomes. This was, they included the overall number of attempts required for successful intubation, presence of hypoxia during intubation attempts as well. And then some other covariates they looked at. We mentioned the airway grade. They also looked at if the patient was in a flat position or not. They looked at the patient's sex, their age, whether it was a trauma call, and whether the patient was receiving chest compressions during the first attempt. So that's their study. And if we have any of our panelists want to interject about kind of how they did this study or anything that they think I missed in the explanation of the methods, please let us know that now.
I think you had I think you covered it. One thing that I really loved about the exclusion of the paramedic student is this concept that you know, all intubators are alike, and I think when you see the statistics of the success rate for paramedic students initially intubating, which Henry Wang did a nice paper on years ago, you're at 50% success rate. And I get very nervous about the studies that kind of lump all paramedics into one. And I think that you know, we're wanting to really account for that particular variance. So that was very nicely done as far as the methods. There's also some questions in the question and answer area that are asking about slides and slides advancing. And mostly we do this podcast just with voice. And so don't think that you're missing out on any slides. That's kind of part of the modus operandi. We sometimes, if we can, include some slides as well.
All right, well, thanks for that. And I absolutely agree. I think, Tony, you hit a lot of the important points, and I want to reiterate a couple of them that I think are key. We talk on this podcast a lot about how much study setting matters, and so taking into context which system was used for this and how often those paramedics are performing intubations, and then whether or not they had any other devices, like there was no video laryngoscopy and some of these other things, are important to keep in mind as we flow through the results section of this study. I also like that you spent some time talking about their definition, the operational definition of first pass success, because I think that's something we have a lot of trouble defining in EMS sometimes. And as we're comparing different studies, it's important to think about, well, what was counted as first pass success? So excellent job on that. Thank you. And if we have no other questions on methods from the audience or other panelists, I say we dive into those results.
I was just going to jump in really quick before we go into results to talk about those outcomes. Again, yes. A very well-designed study, and as Tony just talked about, our primary outcome is this first attempt, first pass intubation success rate. But what I thought was great was that the authors also looked at secondary outcomes, primarily so the number of attempts, of course, but they also looked at adverse events such as hypoxia in particular. So one of the big fears of potentially using this additional device, this Bougie, was that it could add extra time to the intubation attempt and that it could lead to hypoxia because there's a longer duration that we're not bagging our patient. So they looked at the presence of hypoxia, which they defined as a pulse oximetry reading of less than 90%. So they wanted to make sure that maybe they weren't being more successful with intubation, but potentially hurting their patients by not paying attention to hypoxia. So
that is a fantastic point to bring up. And though I fear you were paid by Dr. Jeff Jarvis to talk about the peri-intubation hypoxia. No, I love this point. And this is a really good, in quality improvement language, we call that a balancing measure. It's what are the potential unintended consequences of a new intervention? What should we also be looking at? And so that's a fantastic point that the authors were cognizant that maybe this device may make the intubation attempt longer and could result in some untoward effects, but we'll take a dive into the results and see how that worked out, right?
And I think there's a nice question here from Ray. Welcome, Ray. I'm glad to see your name on here. That asking about the video laryngoscopy and again, setting is everything. And Remley, you're gonna, I'm sure, dive into more of that. But it's important to note that they don't use video laryngoscopy in Seattle, and we are talking about in the setup of this. Seattle does a very good job of recording the audio of every cardiac arrest. At least they were doing that for a long, long time. I hope they still do. Very much like the cockpit recorder, the black box that sort of helps after the event say, okay, this is actually what happened. And I know that a lot of paramedics would be very nervous to think that everything was being recorded, but it really does matter and helps. And I think that if we're going to do a culture of safety and crew resource management, that's one of the areas that we can improve. Either guessing at how, when the intubation started, when it ended. This paper specifically says that they did not record the video of the intubation, and so they don't have the exact start and end in terms of prolonging the intubation. And I also think, just again, one of the setups for this is that these are experienced intubators. Seattle is a tiered system with BLS and ALS ambulances, and the ALS units, so there's not a paramedic on every ambulance like some systems, and the number of cases that are critical for those ALS units obviously increases because the BLS units are taking calls that are less critical. That also means that, again, just setting, if you're not familiar with the Seattle Fire Department, these are paramedics who've got a lot of experience and have been around a long time in most cases. They were asked to grade the view of their laryngoscopies. And so using the Cormack-Lehane grading system, in some studies, we would get worried that a large number of people using a scale that maybe they're not familiar with could introduce some bias. But here, I think, again, in the setting of having such experienced intubators who are used to doing this kind of grading would tell us that the rating of the grade, the Cormack-Lehane grade, is fairly reliable. And then we'll talk about how their results, what the results show.
Absolutely. And we've got a couple of questions related to the technique and whether or not technique was taken into account. So both Aaron and Melissa have asked us about that. And what are your thoughts on that, Dave?
Oh, so of course, the technique of preloading the tube is one that has been discussed. So this is where you have this, again, you think about this long, wobbly bougie, and you've put the endotracheal tube, you've slid the endotracheal tube to the top of it, so that when you're already in, it's just preloaded and you just slide it down. versus just sticking the bougie in first, maintaining the view with the laryngoscope, and then having an assistant slide the tube in. So this is it's one of those like that you only have two hands moments and you need an extra person to do this technique, which it should be one of the concerns with this particular procedure. And I love that you're bringing this up. I love that it's in there. I'm looking feverishly to see if that is the way that they do it, but I'm not finding any description of that.
Right. I also did not see any specific instructions on whether or not a particular technique was emphasized, and I'll open it to Jeff and Tony as well to chime in if you saw it in any of the supplemental material.
No,
Yeah,
I did not.
you're getting crickets because I think we're all looking deeply into this paper going, right, I don't think they ever did actually describe whether they preload the tube or not. So great question.
It is a great question, and it brings up more research questions. And I think that, a good study does bring up more questions. So that's fantastic. And something maybe I'll go back and read more carefully and see if it is in there, or something always can reach out to the corresponding author and ask about. So that's really cool.
one thing that I would add though about the technique, even though we don't know exactly what the technique was, in this study, they actually allowed for a 3-month period in between the prior to implementing Bougie as the routine airway device, and then once they did use it as the intervention, there was a 3-month training period. So they didn't just change their policy overnight. They allowed 3 months for all their paramedics to be trained, both with didactic and then in-person skills education. So they made sure that maybe they were using different techniques in the past. Theoretically, once this study began, they were all on the same page as far as their technique.
That's an excellent point. The effective training.
That is an excellent point. I also think you have to account for policy change versus kind of personal practice. I think that they are very clear in the paper that paramedics had the option of doing bougies prior to, so during the control period, you could have just used the bougie first. And that's important because when you're doing research and you allow the participants to decide the intervention, sometimes that can skew your results. In this case, the pre-period was a retrospective versus the prospective period where you're actually intervening and saying, really, we want you to do the bougie first. And so that's an important change, and might have been a big change for a paramedic who's used to just sliding a tube in and not having to use the bougie unless absolutely necessary.
Absolutely. That run-in period is definitely important. And as you can imagine, in a big service, communicating a change is sometimes a challenge, so that there has to be that amount of time in between. And there were also regular email reminders, which I think is a key to this study as well, so that you don't fall into old habits or anything like that when there's a continuous reminder that this is the technique that we are implementing based on this new protocol. And so I've put up for us figure 1.
They also use RSI in the system. So yes, some of you might be thinking this is just a cardiac arrest research project, but in fact, one of the nice things about the setup here is that the study population is patients who are both trauma and medical, and we'll be able to discuss some of that in the results. But lots of studies have focused on RSI. And so it bears mentioning that it's not just cardiac arrest.
Absolutely. And so as we dive in here, just to give us an idea of the size of the study so that we can hold this in mind as we interpret the different results, we can see that in the standard technique, which was the control period, there were 823 patients that met those inclusion criteria. And then there was the run-in or the training period. And then in the 18-month follow-up period with the intervention, there were 771 patients. So in total, we're looking at 823 plus 771 patients, and those numbers are pretty comparable. So nothing stresses me out so much about, oh, well, they're not the exact. That's okay. That's within normal variation. And so let's take a look at this direct comparison. I think table 1 is really cool because it compares the control period to the Bougie period. We can see were there any systematic differences that we should be taking into account as we're interpreting our results. So we can be looking at them and thinking to ourselves, do any of these differences, are they potentially big enough that they could explain the effects that we're going to be seeing? So we take a look at things like, was the mean age different between the groups, and see here that it's about 55.8 compared to 57.4, no real big differences. Looking at gender, looking at what type of indication there was, so whether it was a medical indication or whether it was a cardiac arrest like Dave mentioned. And we do see a few differences there. So you can see that in the medical ongoing CPR group, it's 40.7% compared to 49%. And then looking at the trauma group, there were in the control period 15% trauma RSIs versus 11% in the after period. But these are just things to keep in mind as we're going into the results. So I wanted to set this up. We don't need to spend a ton of time on it, but I always like to look at table 1, particularly if there are these nice breakdowns of what the 2 study groups look like. All right, now we're ready for, I feel like there should have been a drum roll.
To make a comment. I think
Absolutely.
that we're going to jump in big time into this kind of what does it mean to tube a patient in cardiac arrest versus a patient who's flaccid. And of course, if anyone is listening that works routinely in an emergency department or an operating room, they know that it's ideal to have patients who are NPO, and it's ideal to have patients who are sitting on a bed that is height adjustable. And when, I try to get my big belly out of the way when I'm, on the floor trying to, get the right angle to the right tube, and you're sitting on icky carpet that's got a bunch of emesis, you're bound to make some different choices about how you're able to, get this procedure done. So I think it's critical that we study airway management, and I'm talking not just about the act of putting the tube in, but the entire process and in the pre-hospital setting, and not just focus on the holy grail. So I think this we always have great participation from our audiences when we do airway management, particularly intubation podcasts, and it goes just to show you how important that the entire process of airway management is, and why that has so many different little parts to it, like cardiac arrest, that make these studies so fallible. They just don't, you're just talking about, lots more questions than you have a real sense of an answer. So I'm very happy to see that these authors tackled this with such detail and could at least communicate a lot of the details we need to make good decisions in the future.
Yeah, I think you bring up an interesting point about the complexity of it all. So often, we want to sit here and say either it works or it doesn't work, these binary thinking. And I know Dr. Pepe always says, well, only a Sith thinks in absolutes. So, here we're not doing that, because actually the results get broken down into different looks. And so one of them, for example, we have the overall results here, which, I feel like drum roll for the main result is that between the control period and the Bougie period, there was an increase in first pass success. So it increased overall from 70% to 77%. But I think it's important to look at the different breakdowns within the different grades.
Yes.
Yes. Dave did a great job setting us up and talking about what the different airway grades mean. But then when we look at the difference, so for example, if we look at an airway grade of 1, which is one of the easier grades, we see that first pass success at the beginning of the study in the control period was already pretty high. It was at 91%. And then by the end of the experimental period, or the Bougie period, we see that increased from 91% to 96%, which is a percentage point difference of 5.
Yeah, from great to greater, right?
Exactly. But when we get to some of those other grades, we see that there is more room to grow. And so that's an important thing in quality improvement too, right? Making sure that the measure isn't already topped out, that we're not already in that high percentage rate. So even just moving down one grade to a 2, we see that first pass success started at 60%, and then by the end of the study period was at 85%. So there's a 25 percentage point increase. And I think that it was very wise for the authors to show these different breakdowns. And there's also other breakdowns. So like Dave mentioned, cardiac arrest versus not cardiac arrest. And we'll get to some of those, but I do want to give the panelists room to speak as well.
Yeah, you know, I'm super happy to see these numbers in a bad way. Like like I shouldn't be happy to see that, you know, first pass success rate is 60% on a grade 2, but actually I'm really happy we're having these more detailed conversations, because in the past you see, you know, these horrible averages of first pass success rate that include all grades, and so the difficult intubations get lumped in and we look like we can't intubate. So, you know, if you were to take some of those incredibly experienced intubators in the OR and put them in the environments that we're in, I don't know what their success rates would be. And happy to see that, you know, these are stratified per grade. And just for people who might not be able to see the tables or haven't read the article necessarily, this is table 2. And in grade 4, correct me if I'm wrong, my eyes might be, you know, blurry, but there's like a 20 or 6% success rate and 27% for grade 3. So these are extremely, you know, essentially blind tubes that people are trying.
Absolutely. And I think another point to take into account is putting these tables side by side. So what are the more common grades that we're seeing in the pre-hospital setting? If we were seeing all grade 4, this would be alarming, right? Because we're at 6% first pass success, and then it increases just to 14%. But the bulk of the patients actually fall within grades 1 through 3, and most of them actually in grade 1, if I recall correctly. So I think that's also important to take into account, is just the N within each of these rows that we're looking at.
Yeah, and Dina is saying, well, does it actually, you know, show you the number of patients in each category? And absolutely, you have that breakdown. So, you know, the vast majority, about 190, are in grade 1. 381 of the ones that were in RSI, so about 67% are in grade 1. Yep. And then it starts to drop as you get down to the harder, you know, more limited views. And in RSI, grades 3 and 4 are 72 and 14 respectively. So just about 18% of the patients are in a difficult airway, you know, during RSI, versus in cardiac arrest, grades 3 and 4, you're about 33% of the patients. So where people assume cardiac arrest is easier to intubate because the patient may be more flaccid, or you're able to control it, you're probably doing the RSI for the trauma patient en route to the hospital, or should be. The cardiac arrest looks to be a tougher tube. And that may also be because in that system, they're doing compressions at the same time as they're attempting. So many people have wanted to pause compressions to slide the tube in. And in this system, I'm guessing, and somebody who knows maybe on the podcast can confirm, but the more kind of advanced concept of let the compressions continue is the recommended process. So that in and of itself represents a variation that makes intubation during cardiac arrest harder. So
excellent point.
Note of caution on all of those, but Dina is right. A good study is going to show us not just percentages and pre and post, but it's actually breaking down or stratifying the populations. And this is a great study because they did that.
Absolutely.
I should be noted too, for those that are not seeing table 2, iGel is definitely and supraglottics are used in this system. So you know, we're focused on whether or not this Bougie works, but the question of equivalency between airway management techniques is still very much one that, you know, is kind of a separate question to this one. And I also think it bears discussing that this is not necessarily new. I know that our own Dr. Heegard here at Hennepin County at the time did a study in 2003, which is referenced in this paper, comparing these endotracheal tube introducers with a standard orotracheal intubation. Now, again, as Tony pointed out, in their study, Seattle just uses curved blades, McIntosh blades. They do not use a Miller blade. So some of these studies don't really describe well whether the blade used mattered in their particular pass, and that's important. That's another one of those. Does video laryngoscopy help? And I think Jeff Jarvis would tell us yes, based on what we've seen previously. In this case, they've chosen to stick with one technique, one blade, and limit the variables to see, you know, again, you practice with one tool, you get better at the tool, and don't necessarily water down the number of tubes you do with different techniques. So these are paramedics who all have very controlled experiences. They can actually, if they don't get 10 tubes in a year, they're going to go back to the OR to tube, and that may be impossible for some systems that don't have access to OR experiences, so that their intubators can maintain that proficiency, much like I would say our police officers who maintain proficiency with their weapons by going to the firing range. Here, we've been very lax about the kinds of continued competency milestones, if you will, or performances that we have for paramedics. And I'm hoping someone on this podcast and maybe, you know, some listeners who are interested would say, look, we better study this. If we had regular, particularly simulation and high fidelity simulation practice, much of this concern over exactly how many we get in real life and the percentage of success on first pass attempt might change. So this shouldn't be new to many of us who were, you know, particularly after 2003, at least in the Minnesota system, the Bougie was very much in favor, and some medical directors decided to make it mandatory as a first line and first attempt use. So it's refreshing though to have that study that was done in 2003 only had 20 patients. So here we have an excess of 1,500 patients and nearly 1,600. And so, you know, on a rarely performed procedure that is kind of high criticality, that number tells us, you know, it's a much more useful study than a small number of tubes done by just one service.
Absolutely. Excellent points. And so just to wrap us up here on table 2 before I dive into another look, because there are different lenses throughout these tables and figures, I think for me, the key takeaways here are overall success did increase, but not all success was created equal, so to speak, that there were differences observed within the airway grades. And we saw the biggest changes for those middle airway grades. So either 2 or 3, there were over 20 percentage points difference between that control period and the Bougie period. And now I want to take us, if you're following along, to figure 2, which is a look at the different first pass success, comparing patients who were given RSI who had a pulse and then those who were in cardiac arrest. Because Dave started to talk about this, that, well, we may hypothesize one direction that maybe intubating a patient in cardiac arrest would be the easier one. But here we actually see the results. During the control period, the first pass success for patients in cardiac arrest was 87%. and then comparing that to the control period for patients who had a pulse and then were given RSI, that first pass success was 94%. So actually the first pass success to begin with was lower in the cardiac arrest group. And then again, taking into account how much room there was to improve. So when we're talking about the RSI patients who had a pulse, starting at 94% was already pretty high first pass success. Nevertheless, it did increase. So it went from 94% in the control period to 98% by the end of the study in the Bougie period. Then we look at the cardiac arrest group. Here, first pass success started at 87% in that control period. And then by the end, we were seeing first pass success of 95% in the Bougie group. So definitely a bigger improvement in that group.
I'm amazed at the, when you take something that's already good and you improve it, your improvement rate is going to be much less, right? So I think it's brilliant that the people who are doing it already pretty well are actually showing a little bit better improvement. I really encourage our listeners in systems where we don't have a 91%, initial first pass success rate to try this, because the gain may be much, much greater in systems that are, struggling or have, poor documentation around this. I think and of course, measure twice, cut once is the saying. So what you don't measure really actually doesn't ever improve. So I think that this concept of an implementation of this might be reproducible, and that makes all research much, much better. Is if you can take what they did, reproduce it, maybe we'll see a much larger difference, and maybe not. The study setting here is very unique. There's unquestionably, Seattle has been one of the leaders in pre-hospital care, in particular cardiac arrest and airway management. So the application of this in a more kind of, I guess I would call it, less high performing system or more realistic setting is definitely one that should be measured. We can't guess at this.
And I just want to take a moment to comment on this figure. When you're publishing and you're working on a paper, you try and go through extra steps and do as much as you can to tell your story, right? And I really want to just comment on this graph right here tells the story. It's easy to read and easy to look at, and it kind of encapsulates the whole message of the paper. So this was a really good ad, and when you can do something this quote unquote simple to get your message across, I mean, I think it really does help with the storytelling. So this is just kudos to the authors on putting this together.
Yeah, and Tony, you raise another point too. We offline preparing for this podcast, we're talking about how this is published in Annals of Emergency Medicine. So Annals has a big impact factor, and in terms of where people get to publish their articles, you want to try and get to the journal that has the biggest bang for the buck, the one that has the most prestige, the one that is hardest to get into. This one is not necessarily a journal that's focused on pre-hospital care. So many emergency department-based physicians will read this. It is the official journal for the American College of Emergency Physicians, ACEP. So in Annals, a lot of this work to get these, this brilliant kind of simplicity, wasn't it Einstein that said, the most, making something so complex seem so simple is the brilliance, the intelligence of it all. So I'm butchering that, but work with me. So the concept here is that Annals had this under review for a long time, maybe as long as a year. And this study was actually completed in 2018. So if you want a frame of reference here for how long it takes to get stuff out, This is an important frame of reference as you kind of consider that research that seems like it was published yesterday, you know, this was published in 2021, was in press in 2020 and available for us to look at, but it actually was, the study period was completed in 2018. And some folks kind of wish for instant gratification research like me that can get in and out quick. But some of these, you know, more complex and you know, very, very well put together studies take a while to really articulate very, very well. So just so you know.
I appreciate that shout out. It's an excellent point. It is no easy feat to get something all the way through the peer review process. It is a rigorous process, and reviewer number 2 sometimes hurts our feelings, but it's part of the process. So the authors should definitely be congratulated for taking this project. They could have very easily implemented this improvement and then not shared their learnings with others. And you know, we should be very grateful that they took the time and effort to write up this study and to perform it so rigorously and then share those results so that we can take a look at the results and decide what to do with them. So this is a great study for thinking about, well, what do I do with the results of one study? How do I think about them? And should I implement this in my system? And I think that, you know, if we blend research and improvement science, one of the things we might want to do is say, well, where am I today? Let's take a look at what am I trying to accomplish? Where am I trying to go? So taking a look, I think Michael in the chat here is talking about, you know, even if you don't have an 87% success rate, you can certainly raise your results. So something worth looking at. Now, if you're already at 99% success, first of all, may want to go do some direct observation. And then second of all, think about, is this the best area to target my quality improvement resources, or is there an area where there's a bigger window for improvement?
Yeah, and I'll be completely honest with you here. I am not a fan of the Flex Guide, you know, the very wangly blue plastic device. I love the Bougie.
That is a scientific term.
So yes, the wangly thing gets stored in our airway bags, twisted and turned and coiled sometimes. And and I think that it bears some discussion that in fact, you know, they don't describe the brand of the Bougie, which is, I think, important to me. And you know, I'm an old dog, so I admit that changing my habits is going to be hard. And that if I can see a you know, big old set of vocal cords, I wonder the wisdom of, you know, knowing that I can get the tube in right away, waiting to get, you know, this process done, which requires a second person to hand me a tube, and sometimes that second person is not there. So having said all that, I you know, when I look at this kind of study, I love table 3, in which they actually do odds ratios and the flat position versus not. You have adjusted odds ratios based on whether or not the patient is, you know, laying flat. And look at, you know, the once adjusted, it's a 1.67 odds ratio. So, you know, almost 1.5 times more successful to do the Bougie. And I, you know, I gotta say that makes me think I better practice with what we've got and make sure that it's not coiled up and be ready to use the device, because I do want to have a better shot at helping my patient, right? And just gotta get those new tricks in.
Absolutely. And you bring up a great point. We hadn't really talked about the logistic regression analysis, but logistic regression is a great way to control for some of those differences that happen in a natural experiment, meaning that we couldn't really randomize people in this particular investigation. So we're just left with looking at what were the differences between the control group and then the intervention group and trying to control for those statistically. So here we see in the model where you take into account the grade of the view, you take into account whether the position was flat or not, and then some of the patient characteristics, so whether or patient's gender, patient's age, whether it was a trauma patient or not, and whether the patient was in cardiac arrest. So this is a pretty robust model, and we can see some of the model fit statistics here. But after controlling for all of these different things, so even controlling for potential easier view, Bougie was associated with nearly a 3-fold increase in odds of success. But then I want to go back one figure because I really like this figure. This is figure 3 for those of you who are just listening. It's looking at the use of the bougie on each attempt of the airways. And you see that there's gaps where there's no bougie use and where there's a lot of bougie use, particularly in the intervention period, which is what we would hope. And then one of the questions that comes up for me, and I'm curious to hear what the panelists think, this is something so simple. What do you think are some of the barriers to making bougie use routine in widespread practice? Is there some pride at stake, or what do you think prevents people from just making this normal practice?
Oh boy. Tony, jump in when you feel like it's too bad Bill isn't with us, but he's with us in spirit, so I'll play the devil's advocate. Old dogs, new tricks, all of the change in practice is one thing, but I go back to training, right? Because if you get used to one technique during training and you get used to mannequins on the table and you get used to being able to see the grade 1 intubation, you just don't appreciate why you would need to have this wangly little thing that you use instead. Number one. Number two, chances are the people teaching it are not necessarily going to push the use of the bougie. And number three, I really do think it's a 2-person technique. You've got to have somebody who knows what they're doing. I can't tell you how many times I've sat there with the blue flex glide in where it's supposed to be, and the person who's feeding the tube is actually confused, right? They think that they're helping you remove the blue to put in the tube, and they start to pull on the blue, and so you're not yet you don't yet have the tube all the way through because you just have an untrained assistant who's trying to help you out. So it's not necessarily a technique that is quite independent, and I think that is also one of those, you got to get everybody on the same page, so to speak. Haha, no pun intended.
Now I made Bill Toon a panelist, so watch out.
Oh, I'm afraid now. But Bill's like an old dog. He I don't think they made bougies back when he was tubing, so chances are he's never even seen the thing. But we'll let him comment.
Yeah. No, we just used a stick.
A pen or okay.
A felt pen, with a big feather on it and stuff like that. So
okay, just mark the X around the cricoid membrane and be done with it.
I think that you brought up Dave, an excellent point is that and the gentleman who does airway cam, I'm trying to remember his Richard Levitin. He would tell you, though, about how important it is to be intimately familiar with the technique that you're doing. And he actually recommended not a lot of rescue techniques, that you have, your plan A, B, and C, and then you just drill yourself into that to know it so well. But the other thing to take in is, since in many systems, intubation might be done by a provider. When I was in Kansas, our average provider had a little more than one opportunity a year to even perform oral tracheal intubation. Once you divide it amongst all the certified providers and stuff. And when we looked at the data, we actually found over a third of the providers in the system were never even presented with an opportunity in a 1-year period of time to even perform endotracheal intubation. So I think that they need to be, if whatever you do, you need to do it well. And I wouldn't wait for exceptions. If you're going to do bougie, use bougie all the time. Don't use bougie just for the difficult airways. If you want to get proficient at using bougies, if you're not doing it a lot, you need to be making it part of your routine. Same thing if it's a system with video laryngoscope. Why would you only use it when it was difficult? Why not use it all the time so you're really good at it? So you won't even necessarily know when it's difficult. So, I think those are that you brought up. That was a really important point you brought up there about that. And I just want to give you kudos for that. So.
Oh my goodness. Now mark the time and date. We actually have a Bill and Dave agreement. I love it. I love it.
That's fantastic.
Well, the current, I was fascinated by the fact that Macintosh blade is my favorite blade, but I often like to have choices because if you're talking about pediatric patients, you'll have to be able to use a Miller. And it's interesting here, that concept of limiting choices is one of, you have a limited tool set, but you really know how to use the tools in your tool set. I'm hearing you, and I in general agree. I think we've been trying to align the planes, the view of this, and if anything, this article tells us that the ability to see the target is directly proportional to the success and first pass. If you can't see it, you can't shoot at it. You can't put the tube or the bougie in. So the fact that video laryngoscopy was so successful at not having to line all those angles up says to me, this combination of things may be incredibly useful. And I would hope that some of you who are using video laryngoscopy would tend to do that. We had video laryngoscopy removed in favor of this concept of let's have everybody use one device that we've been practicing or used for a long time. And I hope, I'm sure the numbers will show an increase in performance. I'm skeptical if we're not sort of resorting to old technology that is fraught with all sorts of different issues. But
absolutely. I love the conversation here because I think it's hitting at an important point. We haven't necessarily said it explicitly, and then some of our participants in the chat are making these really great points about, it's probably not just any one single device that makes this difference, right? We're probably not just going to put a wangly little device in somebody's bag and then see intubation first pass success rate shoot up to 90-something%. Every system is designed to get the results it gets. I say that a lot, I know. But I think that's very true to take into account that Ray mentions that there was a culture change and lots of training. So it wasn't by accident that they see these results change. And then Michael has a comment about how it's the EMS community's obligation to continue not only measuring these rates, but improving these rates, because this is part of making a case for why this procedure matters and whether if we're performing it safely and truly improving patient outcomes. So I think there's a lot of fantastic discussion.
Yeah, and I always laugh when we have physicians who say, oh, intubation has no place in prehospital care, and I just laugh and go, well, then I guess we should not use it in the emergency department either. Why are you so concerned with removing a supraglottic airway and putting an endotracheal tube in if it really doesn't matter? If it really doesn't matter, then why would it be? And the truth is, I think it's just everybody's nervous about us doing it wrong. And Michael's comment is dead on. If we're going to do something, we better do it right, and we better study how to do it better in our environment with our tools and our people, versus these studies that are, again, in environments where patients are NPO, the mannequin or the patient is in a position where you just are unrealistically measuring the ability of a person to be able to do the skill. And I do love how on the National Registry airway exam for the better part of 2 decades, it was very clear that the mannequin should be on the floor. But the actual practice in the exam was to put the mannequin on the table, and with their lungs, completely uncovered, so you could see if you were successful or not. So if we're going to play at that game, then I'm not exactly sure what we're doing training-wise, because we're not training like we fight. We're not going to really actually improve first pass attempt success rates, and need to really re-examine, take a hard look at ourselves, and not necessarily wait for others to come judge us. So nice that again, Ray is making a good point about culture. It's just a culture. It's how we think things should be and kind of how they have been.
Absolutely. And this has been a really good discussion and a really excellent study that I hope to see people taking into account some improvement science and testing it in their system, and obviously considering the nuances within a system before just rolling out some broad change. And then obviously testing things on a small scale first is really important. But since we are at the top of time, I will open it one more time for any last comments from any of our panelists before I thank you all. This has been just a really fantastic discussion.
Yeah, I'll just end by saying congratulations to the authors on publishing this great work, and thanks for everyone for joining today.
Thanks, Tony. And Jeff Rollman, any last comments from you?
Nothing more to add. Yeah, this was a really interesting study, very high performing system, so probably not going to necessarily see these results everywhere, but really well done, and hope to see more from them.
All right, Bill Toon.
Yes, the authors did an excellent job, but this is a great model for other people who want to look at the improvement science for their system, if they want to look at it in this topic area, to how to get some ideas. And you should look at the National Association of EMS Physicians position paper that they have that talks about an airway registry and collecting the data for an airway registry. And many people many people don't know that exists, so that would be very worthwhile to look at.
Absolutely. And I'll end too by saying, if you look at the systematic review that Chu did, that was also reviewed in Annals. There was no difference, quote unquote, when you do the systematic review. So there's no risk of using the Bougie. And here we have a clear indication that it improved. And so for me, this is a big paper. It should actually make us all really reach for that Bougie, and it should make a whole bunch of us do secondary research that confirms that, with all of the variations that you've discussed in the comments, like video laryngoscopy and intubation settings. So.
Absolutely. And I would like to end by thanking the audience. I think, like I said earlier, good study raises more questions and makes us want to dig in further. And Melissa had some great comments about some potential future research and different lenses that we might want to look at this with. So I hope that this does spark more research. And I want to congratulate the authors again and thank them for the effort that it takes to publish such an excellent study. And with that, I will carry us out. So I'll put us here. Just as a reminder, we have the Education Research Journal Club podcast Friday, July 23rd. And we will be back here again with the clinical version of the podcast, second Monday of the month, as always, August 9th. So thank you all for listening and look forward to chatting with you all next time.